Hello, today we're going to talk about nursing care of people with PTSD and other trauma-related disorders. After this lecture, you should be able to discuss how resilience plays an important role in the prevention of mental health challenges later in life, and apply the nursing process to recovery-oriented interventions for a person with post-traumatic stress disorder, and develop wellness strategies for a person with post-traumatic stress disorder using trauma-informed care and evaluate the role psychological trauma plays in the development of various mental health disorders. So the first thing we're going to talk about is stress. And all of us experience some level of stress in our daily lives, and that can be completely normal. But this response varies from person to person as to how much stress someone has and what might stress someone out that another person may not feel stressed out by. Um, if a traumatic event happens, one person may have a severe stressful response to that traumatic event, where another person who's experiencing the same event may have some stress, but later on in life may look back at that and not feel stressed about it at all. So one person may develop a severe emotional reaction like agitation or fright, but another more resilient individual may be hardly aware of the traumatic event later on in life, and it doesn't affect them anymore. So emotional problems and mental disorders can develop as a response to the traumatic event. And traumatic events can be physical trauma, which is trauma resulting from bodily injury, or psychological trauma, so emotional injury caused by an overwhelming, stressful event that threatens our survival and sense of security, and that activates that flight or fight response, or fight or flight response. So, what are some trauma and stress related disorders, and when do they start? So, there is no way to determine when a traumatic event is going to happen, at least not usually. Usually, if something traumatic happens, it comes out of nowhere and it's unexpected. In children, exposure to trauma can cause enduring emotional problems that lead to mental disorders that begin in childhood and then progress into adulthood. One of the most traumatic losses for a child is the unexpected death of a loved one, which can lead to multiple psychiatric disorders. In a small but sustainable number of patients, grief can become a persistent and disabling disorder, and this condition is called prolonged grief disorder, and that is one of the trauma disorders. And this can require specifically like targeted treatment for children. So, childhood psychological, physical, and sexual abuse can lead to lifelong struggles with trauma and stressor related disorders. So, this is how we're kind of talking about how trauma and stressor related disorders can develop at any time throughout the lifespan and starting with childhood. Some children experience a traumatic disorder called reactive attachment disorder, or RAD, and this is typically diagnosed in children. RAD results from a lack of adequate caregiving and is characterized by difficulties in forming healthy emotional attachments with their caregivers. So symptoms can include withdrawal, fearfulness, and difficulty in emotional regulation. Another trauma stressor related disorder in children is disinhibited social engagement disorder, or DSED. Um, so this involves a pattern of behavior where children are actively approach and interact with unfamiliar adults without hesitation. So this disorder is also linked to inadequate caregiving. So they don't have they don't form that attachment and that bond with their caregivers. In adults, some other trauma and stressor related disorders can be adjustment disorders. So these occur in response to specific stressors that can manifest as anxiety, depression, and behavioral issues. Symptoms arise within 3 months of the stressor and typically resolve once the stressor is removed and the individual adapts. So this adjustment disorder is really like they're having a trauma, they're experiencing acute amounts of stress, anxiety, and depression, and having some behavioral issues. But after a few months, maybe with some therapy, maybe some medication, it resolves. And so they're able to move on and adapt. There's unspecified trauma and stressor-related disorders. Now, this category is used when symptoms cause significant stress and impairment, but they don't meet a full criteria for any one of the specific disorders, but it's clearly linked to a trauma. And then, of course, there's military violence, which is responsible for lifelong effects for deployed service members. When an adult experiences trauma, memories of a lifetime of previous traumas and abuse influence the current experience and response. Older adults typically experience some traumas surrounding loss of partners, friends, and family members through death, marriage, relocation, and these things can often add to the trauma. As I mentioned earlier, with people having different levels of resilience and that being able to help them cope with the stress of a trauma. So, what is resilience? So, resilience is the capacity to withstand stress and catastrophe, and it accumulates over time. So, this reduces the impact of risk factors to future mental health challenges and enhances our ability to bounce back or recover from stressful experiences. So people who are less resilient or have anxious tendencies may be more likely to develop a depressive disorder. So I would like to talk about post-traumatic stress disorder. So post-traumatic stress can occur following exposure to an actual or a threatened traumatic event. So traumatic events can include those that are directly experienced, witnessed, or learned about from others, or repeated exposure to an adverse event. So examples of traumatic events are violent personal attacks, rape, military combat, natural disasters, terrorist attacks, being taken hostage, incarceration as a prisoner of war, torture, an automobile accident, or being diagnosed with life-threatening illnesses. So the clinical course for this. Symptoms often develop 3 to 6 months after the event. About one-third of the people diagnosed with PTSD develop chronic symptoms, and the symptoms fluctuate in intensity with time and are usually worse during periods of stress. Children with PTSD may react differently than adults, and symptoms that happen after the event and last longer than 1 month can be diagnosed with PTSD, but symptoms less than 1 month do not meet the criteria. So if someone was in a car accident 2 days ago and they started having nightmares and flashbacks of the accident, and this persisted for another week, they cannot be diagnosed with PTSD until those symptoms have lasted longer than at least 1 month. Sometimes they may not have symptoms at all, and then suddenly, 3 months later, or 4 months later, or 5 months later, they suddenly begin to have flashbacks and nightmares about that accident. At that point, they can also be diagnosed with PTSD. So generally, when this is diagnosed, there's 4 general areas that appear. There's usually intrusive symptoms, which is avoidance of people, places, or objects that remind them of the traumatic event. Negative mood and cognition, or negative thoughts associated with the event. Hyperarousal, which is characterized by aggressive, reckless, or self-destructive behavior. And sleep disturbances or hypervigilance for at least 1 month. So those are 4 items that meet the criteria, and I'm going to break down each one. So what is intrusion? Intrusion is an involuntary thought, memory, or dream associated with cues that symbolize or resemble the original event. So there's these thoughts that just keep coming into their head, and they just can't stop thinking about it no matter how hard they try. They have terrifying flashbacks and nightmares. Loud noises can cause this to happen, or maybe a strong odor that's associated with the event. Say it was a car accident and there was leaking gas, and then when they go to the gas station the next time or a couple months later, they smell gas while they're pumping gas, and it brings on these terrible flashbacks. So these can be associated with the trauma, causing flashbacks and dreams. and then consequently it affects the individual to avoid that stimuli altogether. So that second one, mood and cognition. So after a traumatic event, moods become more irritable with episodes of explosive anger, fear, guilt, and shame. So individuals with PTSD, they often have difficulty experiencing positive emotions such as happiness, love, and joy. The thought process becomes distorted with exaggerated negative beliefs or expectations about themselves, others, and the world. And they may not believe that other people can be trusted, um, and they might think that they're terrible people. They might think that they're responsible for every bad thing that's happened to them. With cognition, there are some dissociative symptoms, and what dissociative symptoms are is a disruption in normally occurring linkages among subjective awareness of feelings, thoughts, and behaviors and memories. So derealization is like feelings of unreality, or depersonalization, that experience of self or the environment as being strange or unreal. So there's periods of disengagement from the immediate environment during stress, such as like spacing out or feeling outside of your body. And there's alterations in bodily perceptions. There's some emotional numbing, those out of body experiences. And then there could be some amnesia about abuse related memories. Um, this can also be called dissociative amnesia. And that's like the inability to recall personal information related to the traumatic event. And an example of that would be if someone was being kidnapped, but they only remember waking up in a strange place after they were kidnapped, but they can't remember the details on how they got there, even though they were conscious the whole time. And that amnesia can last weeks to months and sometimes may or may not be recalled. The third and fourth symptom there of the four symptoms, the hyperarousal, is after a traumatic event, the stress system may go on permanent alert. And so the traumatized person is hypervigilant for signs of danger. They startle easily, they react irritably to small annoyances, and sleep very poorly. They can be irritable and overreact to others, which causes others to avoid that person. And then they'll have dysfunctional sleep patterns. There's a diagnostic tool here from the National Center of PTSD in Boston. They created a checklist that generally goes over these different categories, and a score of over 33 should be considered for PTSD treatment. It's not a definitive diagnostic tool, but it's something that can help someone be diagnosed, and we'll go over that more in class. Some risk factors for PTSD would be a prior diagnosis of acute stress disorder, which we'll talk about a little bit later, but that would be having a PTSD-like reaction to an event, but it doesn't persist longer than a month. Also, the extent, duration, and intensity of traumas involved. Environmental factors can also be a risk factor. High levels of anxiety, low self-esteem, existing personality difficulties may increase the likelihood of PTSD developing. Women are approximately twice as likely as men to be diagnosed. Men's triggers include fire, disasters, accidents, assaults, combat, and being held captive, whereas women's triggers tend to be associated more with anxiety, depression, child abuse, sexual and or physical abuse, and traumatic events that happen prior to the age of 18. Symptoms of PTSD fluctuate in intensity and increase during periods of stress. Childhood cancer survivors are at an increased risk due to chronic hospitalization and fear of dying. Veterans returning from Iraq and Afghanistan, especially those who have seen combat, are at an increased risk. And most common among enlisted, also healthcare professionals and combat specialists, those groups of people are all at an increased risk. Earlier, When I talked about the objectives for this lecture, I talked about being able to use trauma-informed care. And so I want to talk about what is trauma-informed care. So recovery takes time and involves support and patience from family and friends. So trauma-informed care is very important. Early recognition of symptoms and treatment lead to more successful outcomes with less likelihood of major complications. So trauma-informed care seeks to realize the widespread impact of trauma and understand the paths of recovery, recognize signs and symptoms of trauma in the patients, families, and staff, integrate knowledge about trauma into policies, procedures, and practices, and actively avoid re-traumatization to the patients. The core principles of trauma-informed care are safety. So we want to create a psychologically and physically safe environment for the patient and the staff. Trustworthiness and transparency. So building and maintaining trust among families and health caregivers. Peer support. Identify and establish a system of peer support. Collaboration and mutuality. Reduce power differential between the healthcare staff and the patients. Empowerment and choice. Focus on strengthening resilience factors. Cultural, historical, and gender issues. Recognize and address historical trauma. Adopt policies and processes that are responsive to cultural needs. Recovery with antidepressants like SSRIs, SNRIs, using benzodiazepines, and beta blockers. An off-label use of prazosin can be helpful, and that reduces nightmares. Cognitive behavioral therapy for better coping strategies. There's something called eye movement desensitization and reprocessing therapy. And this therapy involves having the eyes move across a pleasing visual while thinking about the trauma. So they look at slideshows of different, very nice, pleasing looking images. And this helps reduce the negative effects that the trauma has on the person's anxiety and stress levels. There's virtual reality exposure therapy. This is something that has been popular with veterans to kind of give them some exposure to combat again and being able to cope with that. There's group therapy and family therapy. Safety, of course, is always the priority. The patient might be at an increased risk of suicide attempts or suicidal ideation, aggression, and substance abuse. So a careful assessment should include the risks of self-injury, aggressive behaviors towards others due to their hyperarousal, substances used for coping, like alcohol or other drugs, and assessing for potential of withdrawal symptoms while they're inpatient. Suicide precautions may be needed in some cases. So we need to make sure their safety needs are met, their physical needs are met, and then we're going to assess specific mental health target areas. And that's going to include the original trauma. So why are they here? We want to know the specific event, but we don't need to know every specific detail because we want to avoid re-traumatizing our patients. We want to know their specific physical symptoms. And we want to know their emotional and behavioral consequences. This might take place over more than one meeting, depending on the patient's capacity to discuss the traumatic event and to avoid re-traumatization. Some nursing interventions. So establishing wellness goals. Guide the patient in prioritizing their goals. Introduce small changes at a time. So again, those SMART goals. Wellness strategies like sleep hygiene is very important. Healthy stress management and exercise. Mindfulness activities. Journaling would be really helpful just to get some of the thoughts out of their head and onto paper. Any lifestyle changes as needed. And counseling. Now, earlier I was saying that to be diagnosed with PTSD, the symptoms have to last 1 month or longer, or they can begin 3 or 4 or 5 months later after an event, and that would qualify them for diagnostic criteria of PTSD. But now I want to talk about acute stress disorder. This is similar to PTSD, but the exposure to the traumatic event causes anxiety and detachment for at least 3 days, but not more than a month after the traumatic event. So this is that example I gave of the car accident that happened 2 days ago, and the person is now having nightmares and flashbacks, for the next week, but it's going to resolve before the length of a month. Now, this can develop into PTSD if the symptoms last longer than a month, or if they come back again 3 to 6 months later. But in the meantime, in the acute phase, this would be diagnosed as acute stress disorder and may never represent as PTSD. Military veterans. Military veterans refer to people who have served in the armed services. There's about 200,000 service members transition to civilian life every year. And by 2040, it's projected that there will be about 12.9 million veterans living in the United States. Veterans are more likely to suffer from trauma-related injuries, substance use, and mental health disorders. They have service-connected disability, injury, disease, or disability that active duty either caused or aggravated. PTSD is more likely to be reported today than any other period of time. So during World War I, similar symptoms were referred to as shell shock, and later during World War II, shell shock was replaced with the term combat stress reaction. And any long-term effects were considered cowardly by military leadership. And in the early 1900s, some were even tried and sentenced to death for treason if they refused to fight due to their PTSD symptoms. So for a long time, this was stigmatized by the military. It is more, we have a lot more awareness brought to it now, and we're starting to destigmatize this. Okay? Transition to civilian life can be very difficult and stressful. There's much less routine and structure. The first year is the highest risk period, so very high risk period. This is when veterans report chronic physical and mental health conditions, and work satisfaction often deteriorates shortly after they begin a civilian job. They just don't have the same type of fulfillment and job. Post-deployment depression, PTSD, and substance use disorders. So veterans are at risk for suicide, traumatic brain injury, and are likely to experience homelessness. They're at risk for mental health problems, exposure to stressors and traumatic events. They may be at risk, especially if they've had high combat exposure, history of concussions, high stressful life events within the past year, and if they have low social support. So if they don't have a good social support system when they come home, that also very much increases their risk of experiencing PTSD symptoms. PTSD symptoms related to military trauma include startle reaction with hypervigilance being very high on the list, avoidance of memories and external reminders, anhedonia with detachment, so just little joy in life, not really enjoying things, being upset when reminded of the events, and dreams with sleep disturbances. So combat-related trauma occurs when engaging in warfare activities that involve injuries, loss of comrades in the battlefield, and improvised explosive devices, Non-combat related trauma occurs outside of the direct combat zones, and that includes trauma such as military sexual trauma, witnessing the violence, or other serious accidents. Even hearing secondhand about the violence or losing people that they work with due to the violence. Evidence-based nursing for veterans with PTSD is comprehensive, patient-centered care and culturally informed assessments. We need to help the patient identify their symptoms and refer them to services. Screening for military sexual trauma should be included in any nursing assessment of veterans. The VHA has developed programs to address the needs of women and men who have experienced military sexual trauma. Referral to an experienced therapist who has specialized in veteran care would be essential. So, substance use. Alcohol and drug use has been long associated with military and war. Deployment is associated with smoking initiation, unhealthy drinking, drug use, and risky behaviors. Many members see drinking as part of the military culture, and more than 1 in 10 veterans is diagnosed with a substance use disorder. Opiate use disorders often begin with a prescription following an injury that happens while enlisted. About one half of veterans using the VHA are diagnosed with chronic pain that is treated with opiates, leading to dependency and the potential for addiction. So it's important that we assess for polysubstance use, any comorbidities, and the potential for accidental overdose. And we also want to assess for tobacco use, and if they are using tobacco, we need to make sure we're offering smoking cessation or tobacco cessation if necessary. And that is the end of this PTSD and other trauma-related disorders lecture.